Good morning. Please, can you kindly take your seats? I hope you all had a restful night. And congratulations to those of us who were able to join the Beat NCD's Walk Challenge. It was extremely exciting. We had a good time. Congratulations. And for those of us who were not able to join, unfortunately, you have missed out big time. But let's hope that there will be another opportunity for you. Thank you very much. So we want to start today's proceedings. I have here my co-MC from the Federal Ministry of Health and Social Welfare in the person of
Emmanuel Abraham Agbons.
Thank you. So we'll start with a recap of day 2, which would be presented by Dr. Pascal Min. Is Dr. Pascal here? Thank you very much. Before that, yesterday somebody left this. I think it's an airport. So, yeah, you're welcome. Thank you very much. Over to you, Dr. Pascal.
Thank you very much, Dr. Joanna. Good morning, everyone. Good morning, everyone. It seems we are quite exhausted from yesterday, but I want to believe that it was a very insightful session yesterday, since we engaged very well, and as you can see, we didn't close at the time that we were supposed to close, and I believe that there were interesting discussions, interesting presentations, and that was the reason why we closed at that time. So I would quickly just take us through the key highlights of yesterday. From all the 5 sessions that we had panelists, we had presentations, we had country experiences ranging from health capacity building to health financing, sustainable development financing for PEMPLAS activities. Please, can you show the slide? Okay, so before we get into brief details of the highlights, is there anyone who is willing to share with us key take-home messages from the sessions of yesterday? Any volunteer? Any volunteer, please? Okay, Prof.
Good morning, everyone. I am Nora Akinola, a hematologist from Obafemi Awolowo University, Nigeria, Ile-Ife, Nigeria. The take-home messages from yesterday's presentations were such that we had to go back and draw up our own plans to have PEMPLAS effective or implemented at our own centers. But we need to have government input. I think that's one major take-home message that I can take away from there. But I also observed 1 or 2 things, if I may continue. There was a statement that said that the use of point-of-care testing for sickle cell disease was sufficient to make a diagnosis. But I know that we have a a standard of care guideline drawn up by Sickle in Africa, which we discussed last month in June, even in this hall, during the Global Sickle Cell Congress. And these guidelines is supposed to be used to train our staff at all levels. And in the guidelines, you will see that the recommendations for the use of point-of-care testing for sickle cell disease is that you cannot use them alone. You must have a confirmatory test that goes with it. So if you're going to use hemoglobin type SC or sickle scan, there must be confirmatory testing before you disclose the diagnosis to the parents and the family. And then secondly, with family testing. It's
all right,
important.
Prof, thank you so much.
Yes.
I think you are taking all from us. That's good to hear, but thank you so much for your contribution to the takeaway messages from day 2 session. Next slide, please. Next slide. Okay, so with respect to training and capacity building for health workforce, this is very, very key and integral for the PEN Plus process. And we were made aware that there are existing resources. We don't need to reinvent the wheel in terms of training or producing these models. NCDI Poverty Network has resource libraries and e-learning models. And these are very critical key models that we can leverage on, especially for trainings at the district level to build the capacity of the health workforce at that level. We also had Sierra Leone and Malawi share experiences on the trainings that have been done regarding capacity building, and we were made aware that instead of just the short training, it is very necessary to complement that with structured mentorship, ongoing structured mentorship. And then also, there have been technical guidelines that has been recently published by the WHO to support evidence-based management of priority PEN Plus conditions. Next slide, please. For the medication diagnostic and technical innovations in PEN Plus session, we're all made aware that it is very key to identify the huge elephant in the room. And the huge elephant in the room is the medications that are supposed to be available, essential medications for sickle cell disease management, essential medications for diabetes type 1 management, and rheumatic heart disease. And it's very important that we leverage on advocacy and prioritizing lobbying with government agencies to ensure that these essential medicines are available. And not just the essential medicines alone, but also the diagnostics should be made available. Because if you build a health workforce and you don't have enough logistic, how are you going to operate? How are you going to provide quality services for the clients that you'll be receiving under PEN Plus? So this is very, very important. And so we need to improve on procurements, supply chain, and forecasting. And then also more especially, leverage on the existing point of care tools that we have. Next slide, please. Yeah, data is very, very relevant for us to know where we are, track progress, learn lessons from it. And so there is a need for us to utilize the PEN Plus M&E framework that is currently being developed by WHO. Dr. Fashad shared with us the key indicators that are being developed for PEN Plus, a number of them, over 40 of them, but this consists of core ones and optional ones which can be leveraged upon. We saw Kenya sharing their experience with their costed national plan, which aligns very well with PEN Plus, with UHC priorities. And they have been able to budget 1.85 million for PEN Plus operation within Kenya, but half of this is allocated to medicines and equipment, and that calls for renewed efforts from government, from partners, to be able to look around and get funding for these activities in there. Again, Ugandan highlighted what they are doing in terms of integrating the indicators that they have identified under the PEN Plus project into their national data systems. But this hasn't come without challenges. There's been challenges, and we need to learn from these challenges. One of it is that there should be rural digital infrastructure, and this has been highlighted for the need for investment in these digital tools as well as capacity building. Next slide, please. So for case finding, we can do all the good works, but if we are unable to identify, diagnose these cases very early, then we would not be able to manage them well and also retain them in care. And so this is very, very, very key and important. And there are various strategies that we can leverage on to ensure that we adequately identify all the cases within the zones of the PEN Plus referral facilities. And one of such which was shared was targeted screening. Screening in inpatients, outpatients, as well as community outreach, and also tracing of known patients to ensure that these patients are not only identified, but when they are identified, they are retained in care with all the social support systems that we have available to support them. Next slide, please. So lastly, but not the least, in all this, what is always at the back and should be taken very important is the financial muscle to be able to not just let the PEN Plus project be at the pilot stage, but also scale that up. We need resources. How are we going to ensure that we gather appropriate resources, we gather the necessary resources to be able to fund this? There's a need for us to increase domestic investment and also leverage on the existing mechanisms that are available, like the health taxes, insurance expansion, private sector engagement, and earmarked revenues. These should not go in isolation, but we should ensure that they complement each other, and then we are able to maximize and get the best out of it. Now, implementation research is very, very key for us to be able to have evidences to bring out and ensure that it supports the investment cases that we'll be making. So these were a few of the highlights from yesterday's session. I hope we all enjoyed the session, and it is my hope that today would be an excellent day as well. Thank you.
Thank you very much, Dr. Pascal. I think we'll move to the first session for today. That is session 9, Community and Patient-Centered Care. And it's going to be a panel discussion. And to moderate this, we have Vivian Nabita. She's the founder and executive director of the Sonia Nabeta Foundation, dedicated to improving the lives of children with type 1 diabetes in sub-Saharan Africa. She is an environmental engineer turned global health expert, and she brings a unique interdisciplinary perspective to her work, combining technical expertise with a passion for health equity to drive innovative solutions in global health and sustainable development. In establishing the foundation, Vivian leveraged over a decade experience at the United Nations Development Program, where long career they expanded beyond environmental issues to encompass energy, climate change, and South-South cooperation. Her diverse professional background also includes roles at the International Finance Corporation as a project engineer at Rizzo Associates in Connecticut. She also holds an MBA in Finance and Strategic Management from the Wharton School, University of Pennsylvania, and a BSc and MSc in Environmental Engineering from the University of Windsor in Canada. Distinguished ladies and gentlemen, please welcome Vivian Nabetta. Thank you.
I'm guessing. Well, good morning. Thank you for the kind introduction, Joanna. I'm so really honored to be here, but I think before I introduce everyone, let's have Pacifique, Alvern, Yolanda, come join me up front. So I'm so honored to be here, and my name tag actually says Dr. Vivian Nabetta, but really I warn you, I'm just a simple engineer with a passion for type 1 diabetes, NCDs, global health. Okay, thank you. Yeah, no, seriously, sounds that way. I'm so excited to be here because the conversation here today is one that I care so very deeply about, and the model of care that I really believe in. At the Sonia Nabetta Foundation, SNF as we call it, we have long held the view that community-anchored models and patient-led, well, patient-powered, actually, Joanna, the title of this should be patient-powered care, not patient-centered care. But that warriors, as we call them at the Sonia Nabetta Foundation, must be central to health systems if we want to have a chance at really good health outcomes. So I'm thrilled to be part of this panel of deeply respected leaders to talk about just that, to talk about how communities, how systems can be co-created, co-designed, co-operated, co-owned by the very people that they serve. Today we will hear from frontline implementers and an advocate with a decade plus as a type 1 diabetes warrior, and how they're all working to shift systems towards integrated, respectful, community-powered care. So we have 3 goals this morning. The first one, which I think Dr. Pacifique will do really well, is to showcase how community models are transforming care. The second objective is to highlight innovations in patient navigation and retention, and I think Alvern, in his Zimbabwean experience, will do a great job of that, as will Dr. Yolanda from Mozambique. Then, of course, we can't do it without Tino. Share reflections on on the work that is being done from the lived experience lens. So without taking too much time, I'm going to try not to be clinical with time. I think I've talked about time a lot today. But let me introduce our esteemed panelists. Dr. Pacifique Hagenimana will be our first one. Dr. Pacifique Hagenimana is a Rwandan medical doctor with over 10 years of experience in both clinical and public health sectors, including programmatic implementation of projects, budget planning, and execution. Prior to joining Partners in Health, he served as a program manager at Rwanda Pediatric Association, and prior to that, he led a USAID-funded project across 12 districts in Rwanda. He is passionate about adolescent patient care, universal health coverage, non-communicable diseases, especially type 1 diabetes and RHD. Dr. Hagenimana Pacifique clearly brings deep expertise in designing decentralized health delivery systems and community-based health service models. So please give a hand of applause to welcome Pacifique. Pacifique, over to you. You have 10 minutes, and that clock is not forgiving. It'll chime. There you go.
Thank you so much, Vivian. So, And now I think we are energetic. We are now going to talk about the community. I don't know if everyone will try to imagine if we are in the community. Is it possible? Okay. So I'll be trying to take you through the rural community health system in managing severe NCD disease and engaging patients and caregivers in integrated care. So next. So this is the Rwanda health system. You can see it's represented by a pyramid where on the top we have the referral hospitals which are serving almost 13 million population. But on the down of our pyramid, where is the community, we are finding a group of community health workers. So the country made a lot of effort, at least to bring the number to around 58,000. And now one health community health workers is serving around 250 people. Next. So trying to say about the role of the community health workers, it's not easy, but I will try to shape like 4 activities about the area identification and linkage to care, the health education and counseling, patient follow-up and accompaniment, and even advocacy to access care. So when it comes to area identification, a pool of community health workers has been trained to try to identify the signs and symptoms of rheumatic heart disease. So guess what? After knowing those signs and symptoms, they went back in the community, they tried to identify people with the same symptoms, and they brought a huge number of population. So when we did the screening from those they identified themselves, we could find even more than 10% are meeting the criteria and were diagnosed positive. So that's a sign that community health workers, well trained, educated, can play a key role in the health system. And then the same was done for the type 1 diabetes. The same is done to identify those who are in need of medical attention and even to facilitate different referrals to health facilities. So they can identify them from communities, then bring them in different facilities. So when it comes to health education and counseling, they still play a key role in education for both individual and family level. As I've seen, the health community health workers is reaching almost 250 people. So it means it's easy to do a house-to-house and know them and check their members of the community or whom they are responsible, and they can know which types of signs or symptoms they are having. So far, they really play a key role in education and counseling. Also, they do the follow-up and accompaniment in terms of medication delivery and distribution, in terms of helping in the drug adherence, and even to provide to connect with health facilities. Finally, they also do advocacy, at least to access to care. So most of the time, in terms of social support, the government has different established institutions where people can be supported. So since community health workers know them, they can play a key role to help the community or the local government to identify those who are in need for social support. Next. So when it comes to caregiver, they do, caregivers, those are parents, those are siblings, those are relatives, those are workmates who are staying with patients with severe disease. So they stay with them almost the whole time. So they at least help to remember to take medication, to report any medical issue. Most of the time, if there is maybe a crisis in the night, the caregiver is the one at least to report on those symptoms. If there is any challenge, so they are the one really to support. They can even support in the insulin delivery, especially for less than 18 years to deliver insulin. Next. Then you can see then when we are now talking about the patient himself. So he can influence the adoption of healthy lifestyle. He can influence the adherence to treatment plan. it can influence to empowerment and decision making in terms of lifestyle modification, in terms of early detection, in terms of participation in care, in terms of medication adherence, in terms of understanding treatment. Since this one is the key, why a patient is taking medication, why he or she need to abide to medication, those are different concepts, and most of the time they come from inner. So it means no one needed to come to push you to take medication apart from the inner wish from everyone. And then they also play a role really in working with healthcare providers. If you don't provide how was the status last night, a healthcare providers will not guess. So those are one of many responsibilities, including advocacy, including peer support, including awareness raising, and even the participation in informed choices and consent, especially when it comes to research, when it comes to economic empowerment, the patient himself plays a key role. Then the last slide, I'm trying to check on the time, don't worry. So, you can see I've tried to extract some of the photos in the community. So on the first one, you would see those are community health workers who were graduated or after completing a training on just understanding the NCD screenings. So you can see they are certified. Then after this, they go in the community, they do then those screenings. The second photo in the middle, I think you can see something on this photo? Can you see something? Are we together? Can you see something on this photo? What is this? Those are BP machine. BP machine, blood pressure machine. So those are again community health workers. We donated, we gave BP machine. They can be able to do like BP machine. The same training goes to glycemia, the glycemic machine. They can be able to do glycemia. So those are really power in the community, and they can do amazing job. Then the third photo, this one I will not ask, but that is the insulin pen. You can see those are patients. Those are peer education trainings. Patients themselves, they are just showing themselves how to use insulin pen. You can see this is a generation. What they are learning from there, it's amazing. They won't forget since they are learning from their fellows. This one, I won't ask, they are too small. This is a drone. That's a drone delivering insulin. So we are lucky to have the drone delivering different medical products. So currently it can now deliver insulin at health center level. So this has been even far beyond to the community. So this just to show how the community member is the key to support the disease journey. Let's say it. Then this the community health workers being trained about the rheumatic heart disease symptoms. So after this training, they are able to go to the community and identify people depending on the sign and symptoms they are being told. So finally, this one is super amazing. It was a Penny Plus camp. So we had a Penny Plus camp last year in Rwanda. It was super amazing. We had more than 42 type 1 diabetes and rheumatic heart disease. They were gathered together for 1 week. They were with an endocrinologist, a cardiologist, and they testified that was the first time they had enough exposure with the physician. Most of the time, our patient with the physician, they have like maybe 10 minutes. But when they spend a lot of time with their specialists, with their healthcare providers, they really opened it up. They asked a lot of questions. You know the prevalent topic? It was about reproductive health. I'm not sure if anyone have thought that this is a need for our patient. So I end up by here, and I thank you.
Thank you, Pacifique, for such a rich. Let's give him another hand of applause. Thank you for such a rich presentation, Pacifique. And really, as you sit down, Pacifique, let me prime you for the panel discussion. I have 2 questions for you to think about. The first one is, how are these community health strategies being supported or scaled through national health policy? So think about that. And how do you measure success? Okay. Now, leading into our next panelist, Dr. Alvan Mutengerere. Dr. Alvan Mutengerere is a highly skilled NCD expert clinician and program manager with over 10 years of solid clinical practice, public health leadership, and program management experience. He has been instrumental in supporting Zimbabwe's Ministry of Health to pilot and expand critical NCD initiatives, including PEN and PEN Plus. He is also playing a key role in developing, he has played a key role in developing Zimbabwe's National NCDI Poverty Commission report and the PEN Plus National Operational Plan, and currently serves as Zimbabwe's PI for the PEN Plus program. Dr. Alvan is deeply passionate about advancing national ownership of NCD services and driving advocacy to improve equitable access to quality NCD care for communities across Africa. Look, with such a strong track record in adapting chronic care for underserved populations, we are lucky to have Dr. Alvan. Please, let's give him a hand of applause.
Thank you so much, Vivian, for that introduction. And today I'm just going to take you down south in a country called Zimbabwe, which is a landlocked country bordering Mozambique, South Africa, Botswana, and Zambia. And we are going to share with you our experiences in patient navigation and also some of the things that we did to actually retain our patients in care. Next slide. So to start with, in Zimbabwe, we have 3 PEN Plus clinics. The first one is at a provincial hospital, which is slightly higher level than the district level hospital. And then we have other 2, which are at district level hospital. So in our case, we get to witness some differences and also advantages of implementing PEN Plus at a higher level and also at the first level hospitals. Next slide. So now I'm going to take you through a pictorial presentation concerning the patient navigation and also retention and care. Next slide. So some of these innovations which are coming, these are innovations that help to motivate patients to continue coming to our clinics, motivate patients to continue seeking care at our clinics, and also to continue doing what they should in order to take care of themselves at home. So the first thing that we have is we need to have knowledgeable and confident healthcare workers. So this is very important because a patient needs to be attended by a healthcare worker who is very confident and who also knows what they are doing. When a patient sees that a healthcare worker is very confident and is knowledgeable, healing will actually start before the medicines actually commence. So this is a very important aspect, and this is done, in our case, through didactic classroom training. We have on-site clinical trainings and also mentoring, which involves one-on-one teaching between the clinicians and the mentors. Next slide. Patients also require a one-stop shop. So patients, they want to have all the services done and delivered under one roof. So we must make sure that our clinics, they are well equipped with equipment to screen, diagnose, and manage the NCDs. They must be well equipped with medicines as well, so that, after all the consultation, after all the investigations, a patient can actually go home with a pack of medicines and knowledge on how to take care of themselves. In terms of medicines, I can tell you that, one of the things that also really drives patients to continue seeking care is the availability of medicines at the facility. During the first days of our clinics, patients will actually call each other. So someone will come to the clinic and then someone will actually call, did you get your medicines at the facility? Are there medicines? Then they said yes. Then if there are medicines, they say, okay, tomorrow I am going. So initially, maybe before patients were really educated, they would think I'm supposed to go to the facility just for medicines. But for us, we took that advantage to say, okay, let's make sure that our facilities are well stocked. Patients initially would come for those medicines. We will take advantage that they have already come. We'll do all that is required, educate them, investigate them. And now with time, patients really understand that having this condition is not only about taking medicines, but it's about the whole package of care that I get when I visit the facility. So that also has a very good impact on the retention. Next slide. Patient empowerment is a very, very important role in ensuring that patients are actually living the way they should. We clinicians, we see these patients maybe one day a month, but for the 29 and 30 days that they are alone at home, they should be equipped to know how best to take care of themselves. So, firstly, the healthcare workers must be taught how to communicate with patients. That is very important because some healthcare workers, they use the tool of fear to communicate with patients. If you don't do this, you are going to die. If you don't do this, you are going to complicate. That is not the way. Healthcare workers need to be taught on how best to actually deliver a message to a patient in a friendly way. A patient mustn't feel that, this is someone who is super superior, and if that is the case, then they will actually have a barrier. So we do this through patient guardian education on the ward, demonstrating with the patients what they should do. For example, the type 1 diabetics, really sit with them with the insulins, tell them you are supposed to draw the insulin like this, give them a chance to do it whilst you're still with them, so that you can really know that patients have understood. And also the community component, education as a group within the communities, it is something that also helps increase awareness of NCDs among patients and also within the community. Next slide. We'll continue with the patient empowerment. So we also have support groups. Support groups, these groups, they enable patients to gather and share their experiences. So some patients, in our setup, they live very far away from each other. And a patient, I remember there is a child who thought he was the only one with type 1 diabetes at their school. And so because of that, they are not keen to actually share even with the teachers that they have this condition. But with the support groups now, they get to meet with other patients with the same condition, and they know that they are not alone. And that on its own actually increases the patient ownership to say, okay, this is what I have. I am not an outcast. I'm just a normal someone. And others also can have such a condition. So it actually helps the patient to accept what they have. We have camps that we also do. This could be type 1 diabetes camps. We are fortunate that last year we also managed to include some patients with rheumatic heart disease and also with sickle cell, just to show them, that you are not alone. There are others who also care about you, also with the conditions just like yours. And also, we have some warrior support. We are happy that one of our patients attended the warrior session. And this we have seen to be very, very useful, because this guy is very important. He teaches patients. He comes to the clinic. We do not pay him anything, but he's just passionate because of the knowledge that he got from the warrior camp. And so he just comes, teach patients, help with anything that's needed at the facility. And when other patients are hearing it from someone also with that condition, then it enables them to really understand and take up that message. Next slide. So patient support is also something which is very important. Social support comes in different forms, comes in assisting with hospitalization fees, transport fees to the facilities, and at times we also visit the patients to their homes. Visiting them to their homes is just to show them that, we do not only care about treating you at the facility, but we care about you as a whole. So we want to know where you live. We want to know how you live. You know, at times, healthcare workers, they yell at patients to say, why didn't you come to the facility? But you do not know where this patient is actually coming from. So these moves, they actually help us to really understand where our patients are coming from, how they live. And at times, some of these patients, they will tell you, I can't inject myself just because I do not have any food at home. So if you now visit these patient homes, then you can really understand. These hampers, they are not something that we give, say, on a monthly basis, but it's something just to show love to a patient that we are with you, and the patients actually feel encouraged and really feel part of you. We also have the follow-up visits, even at the homes of the patients. For some who would have missed their appointments, we can just try also to track where do they live. Let's just go and see this patient and see why they really didn't come to the facility. And this is also helping us to let patients know that, you know, this is a clinic for them. Next slide. So lastly, data systems are very important. We need to have good documentation of our indicators, good documentation of our patient data, and this enables us to have an overview of our patient cohort. How many patients do we have? How many patients are actually coming to the facility? How many patients are messing up their appointments? And through the digitalized systems, we are able to actually see so many number of patients, they've missed their appointments, and then we can now employ that follow-up thing to say, if there are village health workers close to those patients, they can follow up with the patients. And one of the things that we also value is ultimately to see the progress or the progression of the patient's condition. So we want better outcomes for our patient. And we can only see that, you know, through good data systems to say, are these patients that we are doing so much also improving their condition outcomes and also quality of life. Thank you so much.
Kept time, huh? Right on the nose. Thank you, Alvin. He kept time right on the nose, which is always encouraging to me. My blood pressure doesn't go up. Okay. I'm going to leave you with your two questions, again, to prime you. And I think it's back to that issue of success. How do you measure success? What does successful patient navigation look like in your setting, especially for warriors in those remote settings, that warrior on the last mile? I want to know how success looks like, and I believe the audience wants that too. Then the second, which I think is important for the Zimbabwean context, is how have you aligned your patient-centered strategies with your with the rollout of PEN Plus, the National Operational Plan, and also just the existing healthcare protocols in your country. Okay, so our next panelist is the one and only distinguished Dr. Yolanda Marcelino. Dr. Yolanda Marcelino is a family doctor and a medical educator. A driving force indeed, a driving force behind strengthening family medicine and chronic disease care in Mozambique. Her work bridges clinical excellence with community engagement in powerful ways, including leadership in family medicine training, holding the position of the Secretary of College of Family and Community Medicine, among others. Dr. Yolanda is a clinical lead of PEN Plus in Mozambique, and as someone who has been instrumental in leading retention initiatives in Mozambique and improving continuity of care across chronic disease areas, so many of them, we are so very excited to hear from her. So please give a big warm hand to welcome Dr. Marcelino, who will give us that experience.
Thank you. Good morning to everyone, and thank you for this opportunity to share the Mozambican experience in innovation and best practice for navigation, patient navigation and retention care. Can we start? So in Mozambique, we have until now only one PEN Plus clinic that is in Sofala province on the center of Mozambique, in Yamatanda district. That is about 150 kilometers from the capital of Sofala, that is Beira. So there we have a sector in the hospital that we are doing attending PEN Plus patient and also PEN patients. We are doing many things to retain patients in our service, but I will focus on these four. The first one is patient-centered scheduling. The second one is longitudinal patient tracking, digital health tools, and psychosocial support also. Next slide. So patient-centered schedule, what we do is that we organize group visits according to the condition, and these group visits, it's not only according with the condition, but also according to the age of the patient, to the location where the patient lives. So we have about 44 patients in our total PEN Plus population that live outside the village of Nyamatanda, and then we have 56 that they are inside the village. So we organize them with these conditions, age, and also location. This is a picture where we are having a group visits. First, they are having like common topics with our mentor, cardiologist mentor, Professor Anna, and then they have their individual visits. Next slide. So this is how we organize the scheduling of these group visits, just for you to see. Next slide. So it has important things and why these group visits works. And one is shared experience, the peer modeling, collective problem solving, and also cultural relevance, mainly in Mozambique. For this condition, they are not well known for the community, so they have the opportunity also to share the culture issues about the condition. Next slide. And then also longitudinal patient track. So we have electronic register to monitor continuity of care for these all conditions. And also that dashboard that flag patients for loss of follow-up, enable proactive tracing. And we have patient register, missing visit alerts, condition tracker, tracing queue, outcome logging, and also stock and supply monitoring. Next slide. One thing that is we started implement this year, and I think it's one of the best things that we implement with the community-based activities, with the home visits, is this tool that is a community-based GPS to be used by the community health workers at the when they are doing home visits. And we also have the involvement of family medicine residents. Nyamatanda Rural Hospital is our first rural site for training for family medicine, so we have residents there. Now we have 3 residents, and they also go to the community with the community health workers also to teach and supervise their community activities. Next slide. Next slide, I also talk about this. So I wanted to show you the key components for this community health worker home visits. We have a patient identification, where we have the ID of the patient with the name, all the identification things that we have. And then we have visit details about date, time, GPS coordinates, as I shown in the last slide, clinical follow-up with the medication, symptoms, and vital signs when they have equipment to do this. Next slide. And also psychological assessment, doing with the moods, stress, screening, social support availability, school and work attendance, also mainly for children and adolescents, referrals and escalations, the need of referral, or any emergency signs observed. Health education, it's opportunity also when they do home visits to educate the family and the patient. And next steps to the next visits to the clinic and the next home visits and follow-up action for the community health workers. Next slide. Yeah, just here to show the distribution of the patients that we have, that as I told before. Next slide. So with the psychological support, we have monthly screening for mental health disorders for patients and also for caregivers, monthly visit to psychologists after clinical visitors, and peer group also. And now we have in total 10 peer groups, and one of them is a community peer group. They choose to do, they prefer to choose to do their meeting at the community. So they choose the place, the time, the day, and they meet once a month, 1 week before the clinic visits. And also peer educator or expert patients to provide also counseling for new cases that we have and to help to reduce stigma. Next slide. Also, social support, we also support with food support and also transport fee subside for the patients. Next slide. These are our partners. And lastly, I want to share with you one thing that we also think it's an innovation for retention patients, as that they can use this tool to also promote and counseling other patients about the condition that they have. And we choose type 1 diabetes. It's a song that was done by one of our health providers in the clinic that is a singer, and it was supported strongly by Dr. Colling. So I want to share this song with you. And as we started with aerobic, and I wasn't there, so you can dance a little bit now and showing this innovation, Mozambican innovation. Please. It's like a rap or R&B, but Dr. Colin, please stand up to dance. Yes.
Ela surge através do consumo excessivo de coisa doce. Muita gente tá a perder a vida com diabetes, yeah. Muitas famílias estão a perder a vida com diabetes. Quando o corpo não consegue controlar o nível de açúcar no sangue. Quando o corpo tem um nível de açúcar elevado no sangue. É diabetes, papa. Toma cuidado, mama. A criança também pode nascer com diabetes. Diabetes é uma doença crônica, yeah. Ainda não tem cura, mas tem como controlar. Diabetes é uma doença crônica, yeah. Ainda não tem cura, mas tem como controlar.
Thank you.
Way to end a session. Honestly, give her a huge hand of appreciation. And I think Jean, speaking about music and just livening up things, this is case in point, honestly. Thank you for this extremely insightful, energizing, panel presentation. Again, 2 questions for you, though. We got to get back to business. Success is an area where I'm sure our audience is interested in understanding sort of what metrics, what signs tell you that retention, not patient navigation, retention strategies are working in Mozambique. And then the second, which relates to the alignment of your patient-centered strategies with your country's, Mozambique's existing healthcare protocols and PEN+, the rollout of PEN+ National Operational Plan. So, all right, so our last panelist, Tinotenda Jikiti. Tinotenda Jikiti, or Tino as I call him, or as everyone calls him, is a passionate diabetes advocate and a certified diabetes educator from Zimbabwe, living with type 1 diabetes for over a decade. He's an African regional coordinator for IDF's Young Leaders in Diabetes and a voice for PEN Plus, amplifying the lived experience to strengthen NCD care in underserved communities. So with a background in financial intelligence, Tino works at the intersection of grassroots advocacy and health equity. Tino, all these health systems are designed to serve you and the millions living with severe NCDs in Africa. So today you don't have a PowerPoint presentation, but we would love to get your reactions about the work being done in Rwanda, Mozambique, Zimbabwe, which is your home country, as presented by our esteemed practitioners. So please share with us your insights, gaps, within the care systems, even more generally, not just from the panelists, from the lived experience lens. Please, let's welcome Tino to the stage.
Okay, thank you. I don't know how to say hi in Nigerian. I mean, there are so many languages. But thank you so much all to our panelists, and thank you to you, Vivian, for the wonderful introduction. I would have preferred you maybe to say Tino just there, but it is what it is. Everyone has got a long bio. Anyways, from reflections from me as a lived experience, someone living with diabetes. So first thing I would say is that thank you. So as someone for whom these systems are ultimately designed, I want to speak maybe from that lived experience perspective. But first thing, I think something that triggered me, or that triggered my fancy when I was just sitting there, the words like, I think first and foremost, I think we need to do better so that we don't use words like adherence, because sometimes they do feel blaming and they're stigmatizing. For someone with lived experience like myself, these are the things that people usually talk about. We need language that empowers, not shames people that are living with these conditions. Something that acknowledges the complexity of the people's lives. So, and also, I think I was really moved by Dr. Alvin's presentation to say, yes, they do home visits, because you're not just understanding, you're not trying to treat the person, you're not just trying to understand the condition, but you want to understand the person, the whole human. You're not only trying to treat the people, but you're trying to heal the person. That's what is important. And maybe the second thing is that for people like me, when we go to clinics and when we see that the healthcare professionals that are treating us, they are knowledgeable, they are confident, and they are not really tired, they don't seem exhausted, maybe they could be overworked. If we see those things, it doesn't really help us. We'll try to move, maybe even to avoid clinics as a whole, to say, I mean, it's not helping. I'm being told the same things over and over. They don't seem to know what my condition is, like type 1 diabetes or any form of severe NCD that we could be living with. So thank you for that, trying to give confidence to the healthcare professionals, because we see that. We want to see a happy face when we come to the clinics. You should be smiling at us, asking us about how is our lives, how is everything, that kind of thing. Because sometimes we know that it's only 5 or less than 5 minutes that you get to spend in a consultation room, right? But maybe 99% of the times we are on our own. We are doing things on our own. But if you try to also to understand where we are coming from, this is one thing that I'm liking the most, because like when you go to the hospitals, the doctors are now talking to you to say, can you afford these medications for those that are still buying medication, maybe for those that are not supported by PEN Plus? The doctors that want to understand, will you be able to afford the medications? Because there are so many options. For example, for type 1 diabetes, we have so many medications, so many insulin types that we have. So the first thing that you need to understand is that, will this person be able to afford the medication that you want to prescribe to them? So you need to understand, we have different backgrounds, right? And mostly, I think one of the things, I wrote this other article this one day to say, it's not always good for us to get these amazing standards of care that are coming from America when you're recommending them to people like us in Zimbabwe or Africa, where the systems are not, they're not like in a way that they can support maybe for us to achieve the standards that you're seeing in the United States. We need to have things that are contextualized. Yes, you can take those great standards from the US, from UK, but then when you come back to our country, you need to have a context to say, will this really support someone, or is going to demand so much from me? I think in a way it doesn't help. And also maybe one point that was made by our speakers is that empowerment is not an optional thing. For me, I got empowered. That's why I'm maybe here, or maybe that's why I got involved in advocacy, because I got empowered. I got exposed into advocacy. That's why I saw that there were other people my age that are also living with this condition. Then I thought, well, I could also try to use my voice. We want to support the healthcare professionals so that they can support our little brothers. We didn't have these access to these amazing platforms that are being created now. Because nowadays I get to go to the hospital, supporting doctors in consultation rooms so that they can understand in a way that they want to say something to the patient. They might say, Tino, can you explain to him what it is, what we are trying to say? So if it's coming from someone with lived experience, someone really wants to do that because they see that, yes, there's assurance. Even the parents, they'll be encouraged to say, if we continue to come with our children to the hospitals, yes, I think that will be something amazing. So it's great. Thank you so much, Dr. Alvin, and the rest of the panelists for trying to empower people living with diabetes, not just them, but also even the healthcare professionals. And also, like, the information shared, I think it also matters in a way that demonstration really does make a difference. When you're just telling me, yes, of course, on the medication that you're giving us, there are these instructions written on paper, but not everyone will be able to understand the terms that are written. Maybe it could be in French, depending on where you're getting the medication. It could be in English, but doesn't mean everyone can understand English or speak it the way I do, or the way that you do. So don't assume that everyone will understand. They might not be able to tell you that they don't understand because maybe they're afraid, because maybe there's fear. So you need to understand. Try to explain them in a vernacular language from our local languages, making sure that they understand, or even tell them to demonstrate to you if they have understood how they're going to be taking this medication when they're home. I think that will be very, very critical and very important. And also home visits, I think they go beyond the clinical care. They are not just about context, they are to see that how healthcare professionals can see the full picture of the person's life, not just the condition that you're trying to treat. Because other people are not dealing with one condition that you're addressing in the clinic. Maybe there's not much awareness for them to understand, yes, it could be diabetes that has been presented or why you have to treat me, but I could have another condition, like underlying condition, because it's for all these autoimmune conditions, there could be other underlying conditions. So maybe the treatment might not be okay. So if you go home, you see what they do, how they are approaching everything. I think that will be help in a way. And also, I think the strong data systems, yes, I know that it does help us a lot. If we are seeing at international conferences, we go there and we are told that there's this, they're always making assumptions of saying how many people are living with diabetes. I do not even know how many people live with diabetes, not just in Zimbabwe, but in Africa as well. But in the UK, they know like how many people are living with diabetes. So I think you need to help us to support so that we have data systems, because I know that data is the talk of the moment. These are the things that can help us to make informed decisions if we want to do advocacy, if we want our health ministers to make policies that addresses these issues. Those are the things that we need to talk about, to say, yes, I think if we know that how many people are living with this condition, so maybe you might have to budget more money on health alone. Because from yesterday, I think on health financing, there was a talk that about 2% is maybe budgeted on healthcare. It's not really okay, right? Because we know that like how much money is budgeted on the army itself for, I don't know, maybe if we are trying to protect ourselves, I don't know what it is, but more money is going to build army nation so that you're protecting yourself from invaders or I don't know, terrorists, I don't know what it is. But also I think that patient-centered scheduling may sound small, but it is transformative. So thank you so much, Yolanda, for that, in the way that you're doing things. Yes, of course, the system might be overwhelmed if you want to do it maybe for the whole country, but maybe try to empower so many people so that it's not you alone. Because for me, I think for people living with diabetes or for people living with any severe NCD, if it's only one person or it's only Dr. Alvin, I'm afraid, even now, I'm actually shaking. I don't know if he is out of Zimbabwe. I don't know, anything can happen. You may want to leave Zimbabwe, maybe for family emergency, but if he leaves Zimbabwe, I don't know how the system is going to be like. So I think we need more Dr. Alvins, we need more Dr. Yolandas, we need so many people, right? Not just me, not just us. We need to empower so many people. Even without us in the room, without our involvement, things can still go on. We are trying to build a legacy. It's not about credit, it's not about making a name for ourselves, but it's about making a system that can continue to go on even without our help, without our involvement. Let's try to leave something that speaks for itself even without us being there. And finally, tracking systems. I think it ensures that no one is forgotten. So we know that some people drop out of care because of the system that has failed them. So if the system is failing me, why should I be going back to the hospital? It's not helping. So let's try to see if there's an understanding, even trying to do these workshops, camps like you're doing. Thank you so much for that. I mean, I speak on behalf of all the voices of people living with these conditions. We want to see those things continue to happen, right? So with all being said, in regards to my reflections, I think I'll end here. Thank you so much.
Is this on? Is this on? Okay. All right. Thank you, Tino. I think we're going to begin our panel discussion with just some of the questions that I posed to you. And Tino, for you, I think the one question that would be interesting to hear would be how it's felt, moving from being a recipient of care to contributing, in shaping systems, and then perhaps even an example of a time where your voice has actually influenced change in Zimbabwe. All right. So back to those questions, my panelists. This is a panel discussion. I think, Pacifique, you've had enough time to let all that marinate. The one question that I think would be interesting would be how are these community health strategies that you spoke about being supported and scaled through national health policy?
Yeah. So thank you so much. I would mention at least two things. The first one is more about the community-based health insurance. So the government did a lot to initiate and now to maintain and even sustain the community-based health insurance, where almost the coverage is more than 70 or 85%. So it means everyone is enrolled into the community health-based insurance. So this now is leading at least to that access to the community. Whenever the community health workers are reaching to everyone, at least there is no issue with the payment at the hospital. Since the subscription is really a lot, I would say maybe $2.5 per year, per tete. So this is really something which is the minimum, and you can access the whole year services. So at least it gives confidence for the access to services, and this is really one of the improvement at the national level and that policy to support that intervention. The second one, I would say also the community health-based, the community health workers who are also playing a key role. So this is a highly intervention, which is they are trained, they are supported by the government, they are getting different incentives, and they are really supported in all aspects to be able to deliver those care. So I would say that those are really the major support from the government to accelerate that community engagement in healthcare.
Oh, thank you, Pacifique. I think that, in terms of measuring success, that's probably one metric. So I'll jump into that thread of measuring success with Alvern. So especially for the patient, the warrior in that remote rural setting, that last mile, how do you measure successful patient navigation? What does that look like?
Thank you so much for that question, Vivian. So in our case, our successes are measured in various ways. To start with, I'll start with the data systems. Like I said before, the data systems allows us to see our patient cohorts, to see our patients who are coming to the facilities and those who are not. So by just looking at our dashboards, you are able to see maybe these are the patients who have missed their appointments and they can be followed up. So data systems, they are very important, in making sure that, we really follow up on our patients. The other thing on measuring success is our ultimate goal in treating the patients, that improving the patient outcomes. So we also track the patient outcomes. Are our patients improving on treatment or not? And one thing that we always want to see a trend where there is a gradual increase in improvement of patient outcomes. We want to see, for example, for sickle cell patients, reduced hospitalization, reduced crisis episodes. For diabetes, we want to see improved HbA1c or glycemic control. So patient outcomes are also some of the things that will tell us, our program is being successful or not. And then, shall I go to the next question?
No. I think that, on the retention side, I think Mozambique's experience, Dr. Yolanda might be able to tell us what metrics or signs tell you that your retention strategies are working.
Hi. Good morning once again. Now, just to equilibrate the languages, I will speak in Portuguese now.
Okay.
Em relação à retenção de pacientes, dos indicadores que nós temos é, na verdade, a percentagem de abandonos que temos em relação às principais condições, que são anemia falciforme, diabetes tipo 1 e também as doenças cardíacas reumáticas e também as congénitas. No total da maior parte dos pacientes que nós temos uma taxa de abandono de 4%. E é uma forma de medir também a retenção. Então, essas estratégias todas de agendamento de consultas por condições, os peer groups, porque nesses dias também são os dias que eles fazem o peer group, e o envolvimento e a satisfação dos pacientes em fazer. Nós, quando fizemos a proposta para os pacientes da anemia falciforme, que são os, na verdade, eu sempre digo que são os pacientes e também os cuidadores, que são os pacientes mais obedientes e foram os primeiros a testarmos o grupo comunitário. Nós fizemos um encontro com as mães e também com as crianças e fizemos esta proposta de, ao invés de eles fazerem ou reunirem-se a nível da unidade sanitária, qual seria o posicionamento deles em relação a ter o mesmo encontro, mas no seu ambiente, na comunidade. E foi bastante satisfatório, e aquilo que é a evolução, o envolvimento, o empoderamento destas mães cuidadoras e dos próprios pacientes é excelente em relação a este assunto. Nhamatanda também, pela sua situação, distribuição geográfica, temos áreas remotas onde os pacientes vivem, que é difícil ter o acesso à unidade sanitária. Então, esta parte do suporte social, principalmente em relação ao subsídio de transporte, tem ajudado na retenção desses pacientes, porque se não tivéssemos este suporte, na verdade, teríamos muitos pacientes faltosos ou abandonos mesmo. As visitas comunitárias também, as visitas domiciliares também são de extrema importância, porque mesmo quando nós temos pacientes faltosos, ir à casa e saber o que está a acontecer, porque que o paciente faltou, e entender a posição da família é muito importante. Não só isso, mas também em relação às outras condições em que o paciente também vive. E este suporte que nós temos do treino em medicina familiar também é um suporte bastante importante, porque o cuidado integrado é também um dos pilares da medicina familiar. E quando nós fazemos esta abordagem, quando fazemos as visitas domiciliares, também esta parte é enfatizada. Então, eu acho que é uma grande estratégia de retenção dos pacientes. E algo que, da última visita que fizemos, também me surpreendeu em relação aos educadores da PAR, foi que estávamos no dia das consultas de cardiopatia reumática e estávamos preocupados porque uma das crianças ainda não tinha chegado. E estávamos com um dos pais na consulta, e ele disse: não, eu já falei com o pai da paciente, eles estão a caminho, vão atrasar-se um pouco, mas estão a caminho. Então, significa que estes encontros, estes grupos de pares são importantes, e este envolvimento e engajamento dos cuidadores e das crianças também é importante na sua retenção. Obrigada.
Thank you, Yolanda, and thanks for diversifying the language. Yes, we have to be inclusive. That's a goal. All right, Tino, I think your question is really about how the movement of the lived experience is moving from recipient of care to, contributing to shaping systems. How's that felt?
Okay, thank you so much for the beautiful question. And I think for me, it's been humbling and it's been healing in the way that I feel stronger now. 9 years after my diagnosis, I didn't know anything. I didn't want people to, I never thought I would be talking about diabetes, traveling talking about diabetes. But now things have changed, and now I'm part of the systems. Back in the days, I used to want to understand, when I was young, I wanted to understand. I was dealing with hospitals or systems that didn't understand what living with diabetes was. But now I'm part of the diabetes clinic teams that is trying to really give that person centricity in the care for people that it is trying to serve. Being part of the design mechanisms that we need, we thought maybe these could work. When I share that, how frustrating it was for me to be judged whenever the doctors are not speaking to you right, or maybe when they're saying you're not adhering to your medication, you're not understanding if, though maybe the reason why I'm not taking my medication is that it's ran out, I don't have the money to buy it, so you need to understand. So there are those things that you need to understand. So now that I'm part of the system, this is, now I can now tell the doctors, because I'm not just coming from a lived experience perspective, but I also had to take a course so that I could be recognized in the hospital where I wanted to help with, as a certified diabetes educator. So now we are changing the systems. They're saying, okay, fine, what is it that we need to do? Now, even we do follow-ups, we don't just wait for people to come back to the hospital. If people don't come to clinics, then sometimes there might not be a way for the hospital to, especially for the first-level hospitals, for the primary-level hospitals, to come to you. So now we have like WhatsApp groups, platforms, we follow up on the patients that, hey, you need to come to the hospital. Sometimes they might not feel okay, or they might feel maybe like that they are not in a position to reach out to the doctor to ask, I'm not understanding the things that you told me. What is it that I need to do? So in those cases, now the people can come to me because I'm trying to bridge the gap, and I hope that I will not be the only one. I hope that I'm just trying maybe to create a system or a platform, so when I'm gone, someone else will take over. That there will be a system that we can always learn from to create those practical tips, like not just for they to be me, but I would want to, maybe all over the country, because I cannot be everywhere, right? Yeah. So I think, in a way, also being awarded scholarships to attend conferences, diabetes conferences, like through DDoC, I've been able to attend amazing, extraordinary conferences like ESPAD, ATTD, ESD. So whatever that is I'm learning from Berlin, whatever I'm learning in Madrid, I'm now taking the context to bring it back to Zimbabwe and see how best we can support the people living with diabetes, not just them, but also the healthcare professionals. Okay. What has changed, those kind of things. So, yeah.
Thank you, Tino. That's, I think it leads right into the patient-powered rather than patient-centered, strategies that we are pushing. I think now that question that I had for you, Dr. Alvern, how are you aligning your, these patient-powered strategies with your Zimbabwe, your fellow countrymen's, shared that experience. So how are you aligning that with the Penn Plus National Operational Plan and existing protocols in Zimbabwe? I think that's an important question.
Thank you so much, Vivian, for that question. So I think maybe I'll start with a brief background. So previously, care for severe NCDs used to be centered at maybe central hospitals where they are specialists. But however, that had its downfalls because you have to be booked to be seen by the specialist at the central hospital. And remember, it's the whole country which is coming to one facility. So if you are to book maybe in January, you'll be given a date in June to come and see the specialist. But however, you're a sick patient and your the sickness can't wait till June. So what the government has been doing in the Ministry of Health is to try and decentralize care to the peripherals. So this is actually going with in line with our initiatives of Penn Plus, decentralizing care, task shifting, of having maybe middle-level providers being able to provide the care, and also task shifting even from those middle-level providers to some of the peer educators and also the warriors, so that they can even also assist in taking care of the patients. So the issue here is decentralizing care from the specialized units, first-level hospitals, and also to the community. And this is actually aligning with our Pen Plus work that we are doing. Thank you.
Fair enough. I'm mindful of time, so that same question for Yolanda, just to get Mozambique's experience when the Pen Plus roll out a national operational plan, how these strategies are being.
Yes, in Mozambique, we have alignments with the operational plan, with the Minister of Health in this strategy. I will focus first with the community-based activities. So the Minister of Health now is in a movement of revitalization of the community system that is mainly focused on the training of community health providers that were working before at the community. Now they scale up or they improve their knowledge, and they are being training in the mid-level institutions. Not for Pen Plus yet, but the conversation that we are having with the department is to also include this training, the Pen Plus training, in the whole training that they have. And we have also the family medicine college involved in this alignment. And while the strategy that we are using is, while we are scale up the Pen Plus into the sites in the country, we are also scaling up family medicine to also engage and be involved with the strategy. So I will focus on those two. Thank you.
Thank you, Dr. Yolanda. I think we probably have 5 minutes to close, but I'll take 2 questions from the audience, if that's possible. I see a very eager question from the lady over here, please.
Good morning, everyone. Thank you for your presentations. Wonderful, wonderful presentations. But I think I'm going to start from some of the things I heard yesterday. When one of the when one of the speakers was presenting and talking about Pen Plus having ward rounds. So it's like Pen Plus is a standalone, is it? They don't merge with the hospitals and work with the hospitals, because if it's that way, then we're going to have problems with sustainability, continuity, and retention of patients. It has to be part of the fabric of the hospitals. If not, it's going to be a problem. The other thing I have is about community health workers. We have a lot of experiences with community health workers, patent medicine dealers. In the past, because there weren't many pharmacists, they were using patent medicine dealers. They became lords on their own and were managing patients they shouldn't manage. We're giving medications. However, I give you an example with patients, my kidney patients. A patient comes with fever. You will give that patient naproxen, Indoseed, diclofenac, paracetamol, about 5 different analgesics. And of course, that fever would go. But as the fever is going, the kidney is going. So I don't know how we're going to control that. And knowing our people, it will be difficult to control. So there are so many questions I have, but I'll leave it at this. Thank you.
Okay. I'm not sure if that's a question or a comment, but I think in terms of, let me divvy it up this way. Pacifique, perhaps you can handle that question on, the community health workers.
So thank you so much. Basically, about the community health workers, you are right. Even when you see what they are doing is really a lot. So currently we have 4 community health workers, 2 occupying of maternal and child health, and 2 more occupying of NCDs and other conditions. So it's nice to try to limit and facilitate their access, since if we overload them, they will end up really doing a lot of things. So for our case, community health workers, they are doing like home-to-home visits, for example. So where they are able to know like patient and they know medication they are on, then they can help them to take those medication. And this is integrated into the system, even if others we talk about. But the community health workers are working through the whole set of the system, as well as the Pen Plus. When patient is there, we are not saying this is Pen Plus patient, rather than having been integrated into the system. Thank you.
Yeah. I think that reaction touches on your first one, but maybe Alvin, you have a mic right there, can comment on the separation of the Pen Plus program and the hospital network.
Okay, thank you so much for that question. So for us, we see Pen Plus as a program which is coming to complement the whole healthcare system at the facility. Pen Plus is not coming to stand in a silo, but just to complement everything at the facility. Pen Plus supports the lab, supports the radiology department, supports the pharmacy, supports the healthcare workers. And these people are not only doing Pen Plus work, but they are actually doing everything. So Pen Plus is also coming at a facility using the existing infrastructure. So we thought also for sustainability, let's use what's already there. Existing infrastructure, existing healthcare workers. We are actually enhancing the knowledge of the healthcare workers who are already there, who are actually treating both the severe NCDs and even the pen conditions. So whenever we are doing our trainings, it's a training which is touching both the Pen and the Pen Plus. Yeah. So it's coming to merge with the system, not as a standalone. Maybe the name Pen Plus is just for now for identity, but otherwise it's something which is coming in to complement the whole system. Yeah. Thank you.
Thank you. Do I have time for just one question or no? Should I wrap up? Do you mind having a conversation maybe afterwards with the panelists? Forgive me. I'm just going to wrap up. Thank you, everyone, for such a compelling conversation, really, and all the insights. I think at the SNF, we've seen firsthand what happens when people with type 1 diabetes, warriors, and people living with severe NCDs transition, like Tino, from care recipients to activists, advocates, and so forth. I think this is really patient-powered care, and it's exciting to see this work in Mozambique, in Rwanda, in Zimbabwe, and also Dr. Mary yesterday mentioned this in Tanzania. And so from the point of view also of sustainability, community-centered care and patient-powered care is a must. I think the community is invested in their success. The warriors, patients are invested in their success. So it really makes great business sense. And the case for investment that Jean was talking about yesterday, I mean, it's right here. The frontline workers are doing all this incredible work. So really, this alone tells me that the future is very, very bright. And I'm excited to have been a part of this panel. Thank you. Applause, please, for everyone.
Thank you so much. I think they deserve a better round of applause. Thank you, Vivian, Pacific, Alvin, Yolanda, and Tino. I think the key word from this discussion is it has to be patient-powered, not just patient-centered. Let's give them another round of applause. Okay, so there's a slight alteration to the agenda. If you look at the agenda, we would break for tea, and then we go for, we would have the 10th session. Lunch will be moved to the last. We understand that a lot of persons will want to go out and see the town and visit places, so we would move lunch to the last. After the 10th session, we would have the 11th session and then the closing ceremony, after which we'll say our byes and we'll go for lunch. So at this point, we'll go for a coffee break. Coffee break will be for 30 minutes. Please, we would want you to be seated in the next 30 minutes so that we kickstart the next session and don't waste for that time. For the attendants, please, the QR code is already displayed. Please scan it, and if you can't scan it, there is a hard copy for you to pick up, and then you can fill and submit to the secretariat. Thank you so much. So we'll be breaking for coffee now. Thank you.
Help drive sales, leads, or site traffic by getting your business in front of people who are actively searching Google for your product or services you offer. Like this business, Google attributes to 45% of Farai London's online revenue. Reach high-intent customers wherever they are across the Google network, such as search, YouTube, Gmail, and more. Get started with Google Ads today.